Hello, my name is Renato Ambrósio. I'm from Rio de Janeiro, Brazil, and I'm the current president of the ISRS, the International Society of Refractive Surgery, the leading network cataract and refractive surgery society that I invite you and welcome all of you to learn more about our group. We have a tremendous source of information, including the JRS, the Journal of Refractive Surgery, thousands of original video and presentations in our library. And I invite all of you to join our family and participate in this evolving and very exciting field. I'm honored to participate in this great seminar, the translation of ophthalmology. Dr. Sohail kindly invited me to speak about one of the topics that I highly enjoy talking about and learning more and more as much as we can to improve our care for the patients with corneal ectasia. So we are talking about the paradigms and paradoxes. These are my financial disclosure, including Oculus and the Brazilian Artificial Intelligence Networking Medicine, a multi-centered, uh, multidisciplinary and multi-center group from Rio de Janeiro and Alagoas, and we have computer science engineers. Actually, Dr. Aidano Massado just graduated in medical school recently. He just changed his life into being a doctor, along with my friends João Marcelo Lira and Bernardo Lopes, who are great ophthalmologists. And Dr. Edileuza Leão is a very fine PhD on computer science. I start with a quote that from Socrates, as for me, all I know is I know nothing. I would humbly try to interpret this wisdom that we have to learn more and more. And ectasia management is related to this evolution. They represent a true subspecialty. As we know, ectasia was first described 150 years ago, and we have a tremendous increase in the number of publications on PubMed since the development of keratofractive surgery. We have diagnosis, treatment for the clinical setting and also surgical setting, so that refractive surgery can also be seen as an enemy because we know that the weakening caused by the refractive procedure can lead the cornea to undergo ectatic progression. So it's important to screen for patients at high risk for ectasia or keratectasia or iatrogenic ectasia after laser vision correction, or even incisional surgery was also reported. And we have to go beyond the diagnosis of keratoconus and beyond the detection of mild forms using corneal topography. The enhanced screening is related to ectasia risk, not to keratoconus diagnosis. But when we manage patients with ectasia prior to keratoplasty, sometimes they come as refractive candidates. This is a different aspect of because we know we changed the management. We broke some paradigms, as we say, because I remember when I did my residency and fellowship in cornea, penetrating keratoplasty was the only procedure that we could indicate for patients that are intolerant to contact lenses. Now we have much more procedures. We have cross-linking, we have cornea rings, we have fake wells, we have laser ablation, and different lamellar keratoplasties that can be indicated. So understanding the patient is fundamental. And we have to be cautious that screening for ectasia susceptibility is different than diagnosing ectasia, staging the disease, giving the prognostic factors so that we can improve the patient care, clinical management, and follow-up will be also lead by the multimodal corneal imaging. So we have to understand what we have in terms of tools for the diagnosis and this classic wisdom that we have to know ourselves and know the enemy, know what we're trying to achieve from the technology. Those are the hows using multimodal imaging, using topography, shine fluid tomography, whole eye wavefront integrated with corneal wavefront, have biometry, you have tomography from the epithelial thickness side with OCT and high frequency ultrasound, corneal biomechanics, specular and confocal microscopy, and more we have the integration of molecular biology and genetics in our daily clinic. So the multimodal imaging is part of our world today, and it's a challenge to learn about it, to be conscious on how to use these technologies. And we have a master class, it's an online course that I am preparing in the My Learning platform which is going to be online for international ophthalmology soon. When you think about multimodal imaging with the Pentacam, we have multimodal because beyond the Scheimpflug corneal anterior segment tomography, you have axial length and ocular wavefront with the new Pentacam AXL and AXL wave. We have different displays that we have, for example, the histograms that would detect anterior chamber susceptibility for angle closure glaucoma, and we have also the keratoconus indices that are concentrated in the Bell and Ambrósio hesictase display. Interestingly, Bellin also did a great contribution on the progression display with the ABCD. A and B are the radius of curvature at the thinnest point, front surface, back surface. C is thinnest point, and D is distance correct vision. So we can see if the cornea has been progressed, if this is statistically significant considering the repeatability of the measurements. And this is very useful for us to provide clinical information for making decisions. We have also experience with different, also other modalities like the 1-700, which integrates corneal topography and ocular wavefront, and some other imaging tools that we have in the system. And this patient that came as a keratoconus evaluation patient, you see some inferior stiffening, and even though the cornea can have keratoconus without a very steep cornea, but it's a steepened cornea, and you see here there is some inferior stiffening, and this may be a mild keratoconus, which is considered as a low K keratoconus. In fact, 8% of the keratoconus, clinical keratoconus, in about 700 keratoconus patients that we evaluated a few years ago, we had this finding that those cases, they have a Kmax lower than 46, and it could be one of these cases. But when we see the dilated exam, we see some interesting findings on the Hartmann-Shack grid. And if you see the integrated corneal wavefront along with the total wavefront, total eye wavefront, and internal wavefront, you see something that is not only in the cornea. And we see this as the very fine changes on the subluxation. And interestingly, the corneal anterior segment tomography, you can see the asymmetry in the anterior chamber depth, the distance from the endothelium to the front surface of the lens. And even though the cornea is thin, this patient does not have a problem in terms of keratoconus, but a subluxated lens, and is a different situation that we have to address differently, not with cross-linking in the cornea, for example. So the paradox is to understand when to indicate corneal surgery for patients with ectasia. The need for surgery is when there is progression or inadequate vision. And if surgery is indicated, we should do as soon as possible. If not indicated, it should not be done. We have a recent JCRS consultation section in the stromal scar in a patient that had a 20/25 distance correct vision with a stromal scar in the left eye. The right eye is pretty much normal, and I was able to evaluate in very fine detail, and this patient does not have keratoconus or ectasia. So understanding that even though cross-linking is a Nobel Award deserving achievement, we have to understand that prevention is better than cure, and preventing the iatrogeny problem caused by the cross-linking would be the best. And in a patient with 32 years old, I would say that follow-up and understanding that the patient cannot rub the eye will be very important. This is the soul of our campaign, the Violet June campaign, and this message is very important because eye rubbing can aggravate keratoconus and may even cause ectasia. Those are not the same thing. They may look like the same thing in the clinical scenario, but we should be cautious that those are not exactly the same thing. So this is a 17 years old asymmetric keratoconus that presents with 20/25 distance correct vision in the right eye, unquestionable keratoconus. The fellow eye has a typical mild keratoconus. It could be a low K keratoconus if you wish to call it like that. But even this patient is 17 years old, very much allergic. We decided not to treat him immediately, and he came back 3 months later with improved vision. Improved vision, uncorrected and distance correct. Actually, he doesn't wear glasses, and there is flattening in topography. This is a topography from Placido, and the same finding on the topometric maps from the Scheimpflug. So eventually follow-up and oral treatment with B2, ocular allergy, ocular surface optimization, is enough for this patient. And you see in the ABCD, you see some interesting decrease and improvement in vision. So we come from the Bell and Ambrósio display to the ARV display in terms of the understanding of the cornea, beyond tomography to corneal biomechanics, and beyond linear regression analysis towards more sophisticated artificial intelligence with the random forest with live or not cross-validation. This is the publication GRS 2017, in which we had 94 cases with normal topography in which the fellow eyes had clinical disease. 72 of these eyes were not operated. Normal topography was based on the straight criteria, and this is the clinical keratoconus, one eye randomly selected as the normal controls, one eye randomly selected. You have a virtual perfect separation for the clinical ectasia and the normals, and we have a different threshold for 0.29 to detect 90.4% of this very symmetric ectasia of normal topography, and this is an epitome for ectasia susceptibility. So when we have this type of understanding, patients like this one with 2015 would be indicated to be abnormal as a form fruit keratoconus. That's the fellow eye of a patient that has mild keratoconus in the fellow eye, in the other eye. So this is important to go beyond not over, but understanding the need for more diagnostic tools. We have the consensus that true unilateral keratoconus does not exist, but secondary ectasia can be leading to a biomechanical process, environmental process, and it can occur unilaterally. I wouldn't say that it can occur in any eye. So we had an example of this. This patient came as a unilateral ectasia patient, had a great result with a corneal ring femtosecond implantation. He followed in London with Dan Reinstein with his prolific exams, probably on the best, more complete exams in the world, with epithelial thickness done by OCT and high frequency ultrasound. His nomogram he'll find normal. Even we could say that it's even normal in the tomography from Ambrsio with the Gatinel-SAD score. And this patient has a normal TBI in the first presentation, and he followed up a few years later in my clinic, still very stable in the other eye. So it's a unilateral ectasia. Interesting, there are some recent TBI studies that came even with normal topography and normal tomography, and sometimes normal topography, tomography, and biomechanics, considering the CBI, which is a biomechanical factor from Visarerio display in the Corvis analysis. So we are aware that this case exists, and eventually this gives us the opportunity to have more wisdom. Sometimes we know a little bit and we think we are right, but we have to know more to know we are not completely right or even wrong. And this nice wisdom came to the humble ability that we have to keep improving. And so there's a true revolution in evolution, artificial intelligence for keratoconus diagnosis. And we optimize the TBI based on a retrospective, actually a prospective multi-center study. Now it's, once we consider it, the data, some of the data was already considered as a mixed study, but we had 551 normal topography eyes, and these cases would be very hard to detect with even tomography. The low threshold with 1.27, the bad DV3, which is the one that we have in the Pentacam, we detect only 70%. And interestingly, we use different approaches for enhancing the artificial intelligence, and we did machine learning algorithms with multiple processes, including linear regression, decision trees, support vector machine. But the random forest was still the best way of doing this separations. So we have the improvement from 75.7% to 84.4%, and with some of the cases are still in the low range that we believe they are truly unilateral ectasia cases, and we kept very high sensitivity for the clinical cases. And interestingly, some of these high cases with a normal phenotype that have high enhanced tomography and biomechanical indices, they should be understood in terms of their susceptibility for developing ectasia. So when you consider ectasia management, there are paradigms broken, paradox created when to do surgery. The concept of artificial intelligence allowed us to improve the data acquisition, the application, but it has to be combined with ancient intelligence, which is the philosophy, and they are applied. That's the A2I square. Interestingly, individualized medicine is the future for keratoconus, but still with humanized approach that we have to comfort always our patients and telling them about the disease, how to deal with the problems, and not to suffer without the need, with just the lack of information and the misinformation may make them suffer even more. So I thank you all for your kind attention and invite all of you to join the Violet June campaign 2021 to promote awareness about keratoconus. Thank you very much, and I'm honored to participate in this great session. Thank you.